Here we go.
You were live.
Good evening, everyone, and welcome to the WIROC webinar series of 2024. Today's topic is acetabulum defect reconstruction in total hip replacement. As we all know, WIROC, which is the flagship activity of Bombay Orthopedic Society, is around the corner. It is going to take place in December 2024, and we have with us a young and a dynamic organizing secretary of WIROC 24, Dr. Anup Dhamangaonkar with us. Dr. Anup, can you just brief us about the preparation going on at the WIROC?
Yeah, thank you, Dr. Abhijit. The countdown has begun. I thank all the esteemed panelists to join the webinar. This is a prelude to the WIROC, which is the annual conference of Bombay Orthopedic Society. And this year we have got very niche topics planned. They are basically entitled to change the practice of attending surgeons. We have included a lot of controversies and we aim to have a consensus on the same. We include a lot of debates, plan to include a lot of debates. We have got a lot of keynote speakers who's who of Bombay Orthopedic Society and of the Indian Orthopedic Association itself. And then we hope to have a good camaraderie and social networking as well through our different meets. So I thank you all for being a part of this webinar. And I hope to see a lot of orthopedic surgeons joining in the grand scientific extravaganza coming to your doorstep on the 20th of December.
Thank you, Anup, for that welcome note. We have with us Professor Dr. Mohan Desai, who is the Honorable President of the Bombay Orthopedic Society and the organizing chairman of WIROC 2024. Welcome, sir, and over to you for the presidential address for the webinar.
I'm here to learn and listen to scholar. I see Dr. Neil Chit here joining, and I'm here to learn more from them. Without any further ado, I think we should begin. It's time, and we should begin kickstart the webinar.
Thank you.
Thank you.
So, Professor Dr. Mohan Desai, sir, he is also the chairman for today's webinar. And we'll start with the academic proceedings of this webinar. I'm Dr. Abhijit Kale, and I will be giving the first talk on the biological methods of reconstruction of acetabulum defect in THR. I will start sharing it. Is my screen well seen? Can you see my screen?
Yes.
Yes. And am I also audible?
Yes, you can see.
Yeah. Thank you. So acetabulum defect reconstruction is a complex and a challenging task. If you look at the ratio of revision of the femoral to acetabulum component in revision THR, it's almost 2:1. So acetabulum component has a more tendency to failure. When it comes to acetabulum defect reconstruction, there are various classifications, but Paprosky's classification has withstood the test of time almost for last 3 decades, and it's been considered as the gold standard. Another classification used is the AAOS classification. If you look at the Paprosky's classification, it is based on the severity of bone loss and the ability to obtain cementless fixation. The key is determining the ability of the remaining whole bone to provide the initial stability for a cemented acetabular component and for the ingrowth to occur. So basically, initially, there were 3 types: type 1 defect, type 2 defect, which was further divided into A, B, and C, where the lip is distorted but the column is intact. And in type 3, both the lips and the column are distorted. Over a period of time, even type 4 was added, which is mainly the pelvic discontinuity. Coming to the second classification is the AAOS classification, where it basically speaks about the cavitatory defect and the segmental defect as type 1 and type 2 defect. When both are combined, it is type 3. Type 4 defect in AAOS is the pelvic discontinuity, whereas hip arthrodesis is classified as a type 5 defect. When it comes to an acetabulum defect, the Usually the diagnostic workup would include ruling out infections. So infective parameters are done. X-rays, mainly PBH, AP, or oblique Judet views are taken. If the clinical condition demands aspiration, that can be done. And at times, a 3D imaging in the form of CT scan may also be taken up. So once the defect has been quantified and assessed, there are methods of reconstructing this acetabulum defect. Biological reconstruction essentially involves direct contact of the host bone with the acetabulum shell, which will promote osteointegration. What are the options available? Either using a highly porous uncemented cup, a jumbo cups, oblong cups, a triflange cup, an uncemented hemispherical cup along with a structural allograft, or a porous metal augments. So how to manage the defect? Now, this was a case of a cavitatory defect in an elderly male. He presented late. And if you look at this defect, it's mainly by Paproscus type 2C, where it's a complex type of protrusio, where there is a medial as well as superior migration. And intraop, you can see that the column lips are intact, but the medial wall, that is as well as the anterior column, that has been what has been pushed in. So intraoperatively, after placing in the trial cup, you can see the defect behind, and that was all filled up with a particulate allograft plus autograft. And that was how it was reconstructed. So there is a judicious lateralization of the cup in the post-op X-ray, and you can see the cup line flush to the Kohler's line. The second method of reconstruction is using the augments. Augments, as per the Mayos type, they can be used in various configurations. The type 1 is a flying buttress augment, the type 2 is the dome augment, or it can be used in a footing mode. So these are the various types of trials that we get for the augment here in India. It can either be a column augment or a slim or the elliptical augment. So when it comes to the first type, the flying buttress augment, this concept has been taken up from the civil engineering. This is mainly used in Paproscus type 3A defect or the superolateral defect. So in the Gothic architecture, you can see the pillars they're supporting from outside. So in a similar way, we are trying to support the defect in the acetabulum. If there is a superolateral defect and if one tries to weight bear on it, the head is likely to subluxate superiorly and laterally. In order to prevent this, one can put in a support on the superolateral side and thereby prevent that migration, add to some stability. This was a case of a post-infection sequelae with a superolateral defect. And here you can see the augment used superolaterally. This is the flying buttress augment. That's how it was reconstructed. Another case, this was an elderly male, post-injury, he presented late. And after assessing the defect, here you can see there is fibrous union of the defect. This defect was reamed. After reaming, you can see the bleeding edges. After the shell was put in, you can see a majority of the shell is lying unsupported. So the augment, this is the trial augment, which has been sitting flush to the trial cup and being held with the wires. Once the final augment is opened up, you remove the trial augment and put in the final augment. There's the trial augment which is going out. And that is the final augment going in. Over the same guide wires, you can drill over those guide wires and fix that augment. In this case, we used a multi-hole continuum cup, and that was the stability we achieved. You can see the augment on the superolateral surface with the intra X-ray, the post-op. Another way to use this same augment, but putting in a different configuration, is known as a dome augment. This is usually used for a superomedial defects, 3B defects. So here you try to match the concavity of the augment with the convexity of the cup. Here you can appreciate the defect. And that's how the augment goes in, and you can pass again the guide wires through that. So it basically goes into the cavity and tries to minimize the size of the defect. So the size of the shell that you will be using also goes down with this. Again, the wires go in one by one and then they get replaced with screws. And here you can see now the size of the cavitary defect has gone down. So comparison by generating on the various types of augments. So flying buttress can be used both in 3A and 3B, whereas the dome augment predominantly in 3A and the footing augment in 3B. This is the footing augment where you try to put it on the base of the acetabulum, mainly the medial wall of the acetabulum. This can also be used in type 2C defect. Or what about pelvic discontinuity? Dr. Neil Sheth, he will be covering it in detail. But when it comes to pelvic discontinuity, acute discontinuity can be managed using augment with an uncemented cup, whereas a chronic discontinuity, which is something like a non-union and has a very little healing potential. So at Pennsylvania, they have come out with a distraction technique where after distract, you distract laterally, compress medially, and put in the cup along with the augment. This was a case where you can see within 4 months, the cup has migrated superiorly and medially. This cup was taken out and now you can appreciate the defect. The discontinuity was fixed with a posterior plate, and even after putting in the plate, you can see a lot of large defect. So here a column buttress augment was used. You can see a slim going underneath it, and that being fixed, a lot of graft was showed in, and then the final cup along with a liner. What is important is the interface. The interface of the augments and the cup should be filled in with the cement to prevent micro motion and thereby prevent the wear debris. So this is very important when one is using augment. This is called as the concept of unitization. And that is the follow-up of this patient, and he's doing well. The other options are to use a custom tri-flange cup. However, they are not available in this part of the world. Here in the preoperative, a lot of pre-op planning is required. You tend to give time that around 6 to 8 weeks, and then once you have done it, it's available, it can be used. A word about a bilopt cups. They have fallen again out with time. Again, they are not available in this part of the world. And we have now newer cages known as the integrating cages, which can be used along with the phase changing liners. So if you look at the recent paper in 2024 Journal of Arthroplasty by the Alan Gross group, even they have favored the use of this augments in midterm as well as long-term results. The complication associated when we use these augments are that a very little chance of superficial infection or a sciatic palsy or even a trochanteric bursitis. So the algorithm that we follow is when it comes to type 2 defect, it's usually jumbo cup. Type 3A, that is up and out defect, you can put in a buttress augment, and up and in defect along with the cup, you may use an integrating or a non-integrating cages. Type 4 defect, Dr. Neil Sheth, he will be discussing in detail. That was in short about the biological methods of reconstruction of acetabulum defect. The next talk is by Dr. Anup Damangaonkar, and he's going to speak exactly the other part of this, which is reconstructing the acetabulum using the non-biological methods. We will take questions on all the various talks at the end of this session. Over to you, Dr. Anup.
Yes, sir. Is my screen visible now?
Yes.
Yeah. So I'm playing the devil's advocate here, though I should agree that I tend to use more of uncemented cups and jumbo cups, continuum cups with some wedges. But there are some times when we need to use non-biological options, that is cages, rings, etc. So what are the advantages of cages and rings? The main advantage is that it brings down your center of rotation once you have an inferiorly placed flange into the ischium, because that gives the correct center of rotation. The main principle on which cages and rings acts is that it protects the structural allograft or your bone graft till it incorporates. So we want to weight bear or load the graft, but we don't want them to disintegrate. And that is the basic purpose of a non-biological or a cage or a ring. So even when we use a highly porous hemispherical component, we would still want to protect a large unstable pelvic component with an augment which is very large with a cage or a ring. So those are the advantages where I would say is that in large defects 3B and above, we still may use the cage. Though it appears to be non-biological, it is needed to have a biological outcome. And why do I say more biologic outcomes? Is that once you have a young patient and you're doing a revision for him, we would expect him to undergo some revision in some stage of his life. What about the bone loss when we are extracting that kind of a TMARS or a highly porous augment out? It will pull out half of his acetabulum. So therefore, we want to have a safer reconstruction for which we want to have a good bone stock. And these cages, once we have an impacted, a well-fitting allograft which is done, and then we are trying to get it nullified or protected with a cage. You look at this series of 50 patients with revisions, 31 underwent a subsequent revision. 1/3 of them could be managed with a hemispherical component itself. That gives us the idea that we need to have protection or good bone stock for every revision that we go in. So what are the options that we have? We have got the Kerbul's cage, the Mueller's ring, the Gans cage, the Gap cage, and the BS or the Buschneider anti-protrusio cage. So we can use the cages when we decide to do a cemented component, a Peprowski's 2 and above, and in 3 and above when we are going to do a cemented or uncemented revision. The original Kerbul's cage is not a new construct. It was devised in 1974 pretty much by hand in the backyard of a surgeon. It was a hemispherical component with 316L. It has got right and left constructs with 10 degrees of version and 6 different sizes. Now, the principle of this construct is that once your hook is engaging into the inferior part of the acetabulum, your flange will indirectly get you 45 degrees of inclination. So the whole idea is once you get your cage in the righteous place, most likely your COR will be in the right place. Once you place a trial in, you know what the defect is. As you can see here, you know where the defect is. Then you need to have a good structural allograft. I think the key to survival of any cage is a good structural stability of the native allograft. We'll discuss why. So these are the case series published in 1974, the early cages, the failures. But then you look at 1 month, 10 years post-op results, no breakage of the component, no migration. Here, when we have morcellized bone graft that is put in and it is not stably fixed, this is the poor initial construct of the allograft, and then we fix that with the Kerbul's cage. You look at 14 years, there's somewhere you can see the screws breaking out, the cage is broken out. I think this is a natural progression of non-biological cages over a period of 5 to 8 years. However, they do not lead to massive mobility or instability of more than 5 mm. But the idea that we need to take home is that the structural stability of the allograft is very important. So this is how we would do it. You would have a template put in, assess your defect, put in a well-structured, well-contoured, well-fixed allograft, and I think that is the key to success. Tanaka has also published this paper on how do you incorporate the graft better, and in which he uses allograft which is mixed with hydroxyapatite, and that leads to a better outcome. Over a period of time, Kerbul's cages have evolved. They are thicker, the hook is even higher or deeper for a better engagement. So then what do you do about when we are using the BS cage, for example? You have a small osteotome that is created. We'll see that space in some time. There's a difference between cup cage, that's what we'll discuss, and a cage augment technique. Now, whenever you are having an augment which is not very well fixed, or it does not have a good contact with host bleeding bone, you need to stabilize that augment with a column construct or a cage. That is basically a cage augment technique. The second technique that people use now is if you are going in for a second revision with a well-fixed augment, but the cup is loose, you can retain that augment and then have in a cage that goes in. That's called an augment retention technique with a cage. So for example, you have got this kind of a construct, and this is 6 years post that revision. You get a good augment, which is neutralized by a cage. Vis-a-vis that, we have got something called a cup cage technique. Especially in chronic pelvic discontinuity, and Dr. Neil Seth will present his innovative technique. It's wonderful. But in other cases with poor healing potentials, you have a deficient acetabulum. You pack that with morcellized bone graft. Then you put a T-Mars or a highly porous hemispherical component. You impact that on bleeding bone. Make sure that you don't blast it off. It's just a secure rotational stability that we need to find that bridges the discontinuity. You fix that with multiple screws. Before that, you have an offloading cage that comes in. So in a cup cage construct, you have got a T-Mars cup, uncemented, and then a cage goes within that kind of a construct of T-Mars, and then you engage that by means of screws. So these are basically cases where your inferior flange will go into the ischium, and a titanium cage is now into the augment or the T-Mars hemispherical cup. The difference between the T-Mars with a cup cage in a cup cage construct, the cage is not very, very rigid as we have in a BS system. So we never use that kind of a cage in isolation. This is a practical technique of how a cup cage is done. You have got T-Mars cup going in. This is what I was talking about this is a similar technique for our BS cages. You first drill with a tap, you go along, find the orientation of the ischium. Then you bend the ilium, the cage, so that it fits on the ilium. It's usually that you need to bend the cup cage towards the ilium. Then you try and place the trial in. When you contour the trial, the final is impacted into the ischium and then punched into the T-Mars shell. Then you cement in the liner. This is the cup cage construct. Now, whenever we have a good construct that is fixed uncemented, we can cut the inferior part, and there are concepts of half cages and in cup cage constructs that are being used now. So obviously, when we have a case or a revision going through 8 years, 10 years, we need to see what do we need to see on a follow-up X-ray. So there are criteria that define loosening of a cage. Type 3 is defining definite loosening. So whenever we have a horizontal or vertical acetabular migration, more than 5 mm, the cage is definitely loose. When there is progressive complete osteolysis or a radiolucid line that goes medially and superiorly around the screws, it is loose. When we have screws which are broken, but if only one screw is broken, it is not considered as a definite loosening. Provided the cage does not show any sign of migration and the angle of broken screw does not change much. If you have a broken inferior flange, the construct is considered as unstable and therefore loose. Type 2 is probable loosening when you see progressive lucencies medially and superiorly on the AP image, and the presence of one single broken screw, but the plane of or the broken screw is not changed in direction. Type 1 is probably or possibly loose. That's when you see non-progressive lucencies which do not involve the screws as well. Complications do happen in cages because most of the cages or non-biological constructs require a wide dissection. You need a wide exposure, and that's when you can get loosening, nerve injuries, dislocations can happen, allografts can get resorbed, or you can have infections that are transmitted because of allografts. Wound healing issues are real, and breakages are real, and they are a part and parcel of these non-biological constructs. The main deterrent is what I would say is incorporation of a well-stabilized allograft. I think this is the only factor that determines whether the cage will succeed in the long term or not. If the flanges are loose or they fracture, they indeed are not supported by a good allograft. I think that is what should be the take-home message through this talk. So allograft resorptions and infections are real again. We conclude saying that yes, non-biological cages or options are really time-tested. What I mean by that is they are time tested for good short to mid-term outcomes. They still have a role in young revisions and highly morbid patients and in financially constrained patients. So use them judiciously. Thank you.
Thank you, Dr. Anup, for that wonderful talk on non-biological methods of reconstruction. So we have covered both the poles of acetabulum reconstruction. Now, the next talk is by Professor Dr. Sen on THR in acetabulum fractures. He has got one of the largest series of acetabulum THR in acetabulum fractures in this country. Somehow he is traveling to Davos for the AO pelvic course. He has shared his talk to me. I will run it from my side. Can you hear it?
Talking about arthroplasty.
Is it audible?
Yes.
Fractures in this field today. We all appreciate that a reasonable number of cases having acetabulum fractures are likely to end up in herp arthroplasty. It could be that it was a good reconstruction of the acetabulum, but the complication like arthritis, avascularity happened. Or it was a poor reconstruction which led to an early fixation failure and eventually now needs arthroplasty, or it could be a neglected trauma care. We must consider that the outcome of any post-traumatic arthroplasty cannot be equated with a non-traumatic hip arthroplasty because of the number of complications which can happen in these cases. We understand that with the cup displacement, the fracture, there will be difficulty in defining the version and the inclination. It could be that we have got a loss of superior wall, we have a medially displaced ischium, so all those things are likely to be altered. And due to the fracture, there are likely to be subsequent adhesions also, or the contractions also, which can give a soft tissue balancing a problem. And maintaining the lift and downset are also an issue. We must appreciate that all those cases which have been primarily operated on now, infection is also one of the possibilities which can happen. So with this kind of a distorted anatomy, with the femur head subluxation, with the avascular lysis or heterotopic ossification, one more factor which is as important is the bone defect which can happen in these cases. So in these cases, in last 13, 14 years, about 300 cases, we had about 50% of these cases actually had a significant bone defect and were neglected. Why? The classical description of a bone defect goes with the Paprosky. We understand that. And this is one of the most common modalities of the defect assessment which has been used as per the literature. But literature also defined it very carefully that in a traumatic situation, the Paprosky classification is not meant for. Why? Because if we compare the features of acetabulum fractures defects vis-a-vis revision THR defects, the loss of bone in acetabulum is acute. The bone quality is not bad. Anatomically, there is a pattern which we define it as a lateral classification. There's a pattern of displacement. Posterior wall fracture and posterior column is very common in acetabulum. They are not common in a kind of a revision scenario. Very essential thing is that the basic construct of the columns remain intact in revision scenario, while it is primarily displaced or fractured in most of the acetabulum fractures as such. So it's a very important issue that we need to have a separate classification. And for this purpose, we have a new classification which we have developed. And in that classification, we put all these conditions as per the lateral fracture patterns with the understanding that they are either non-unions, they are malunions, maybe stable or unstable. Then we sent these classifications to 10 of the most senior orthopedic surgeons and arthroplasticians in the country to have their assessment about the comparison of using Paprosky for the same case as well as the new classification. And we found a significant difference in the two regarding Krippendorf alpha coefficient also, which is too high for new classification, and the percentage agreement also, which were too high for as compared to Paprosky classification. And not only that, the method of reconstruction also had a very much more consensus with the new classification proposed. So it becomes easy. And in this classification, we have type 1, which we say it out that basically the reconstruction has been done, but there is a complication. So we don't have much of the issue with the defect. It could be little of the widening out, and a standard replacement can work in that type 1 kind of a situations. Here also the same kind of a situation is the arthritis, where a standard replacement with the kind of a stiffness can work. Important is posterior wall. Now, this is very common in acetabulum fractures and very often neglected also. And in this kind of a situation, you might get a patient with this kind of hip which is destroyed, acetabulum which is destroyed. So, with that posterior wall, most often we can use a femur head as a graft to reconstruct the posterior wall. Our stability is primarily between the ilium and ischium, but the posterior wall can support that area and it can give us a good outcome. Another case with a similar kind of a big bone loss around the posterior side, which is managed, the outcome is there. Specific issue is that now we have got a less amount of the host bone available for the incorporation and cemented situation. Many times we can use the better quality, higher porosity cups in these kind of a situations. And it may be safer in these cases to use a multi-hole cup, which gives us superior and inferior purchase also. Another thing which we these, because it is all these posterior injuries might have led to a relative weakness of the glutei. So dual mobility cups are supposed to give us protection. We might have a situation when the femur head is totally lost. And these are the cases where we may use the augments. We appreciate that the augments are needed in all those cases where the stability of the cup will be affected by the posterior defect. Their femur head graft may not be adequate, and we feel the proper augments are much better in this kind of a situation. Just like here in this case, we have used augments to give us a reasonable amount of the stability in this scenario. If that is too much of destruction over there and we don't have anything to hold on, in that situations, we may use a 3D printed cups also for this kind of a situation to have the patient's ability back. Now, another situation is when the posterior column is fractured. Now, after the fracture, it might be malpositions. It might be stabilized either due to malunion or a fibrous union. And in that situation, we look at two conditions, a stable and an unstable posterior column. If it is a stable, there is not much of the issue. It can settle very bad. But if it is a non-union, and this patient is likely to present with the kind of a pain over there, and this is or the kind of a malpositioning of there, then we have a big defect. Again, this defect needs a reconstruction of the posterior column to have the cup placement over there because whole of the column is gone. So again, we might need a autograft, we might need augments in this kind of a situation. Here, this patient we did with a large amount of the femur head and keeping into that area as a graft. Or this is another case of a non-union of the posterior column which has been stabilized first. For the in situ, we do not try to reduce it out. It is very difficult, or we may have to do the osteotomy at 2 level to reconstruct all of the posterior column. But mostly in situ fixation does give us enough stability. Then we have a transverse fracture kind of a pattern again, which might be malpositioned but united or stabilized by either osseous or a fibrous union, or it could be unstable as a non-union. Here we have got the A situation where it is stabilized by the plates and it is a fine kind of a stability achieved with a larger uncemented cup. Or we might have a situation like that which is neglected, leading to a lot of bone loss over area. Here we do define it with a lot of a graft over there, we use a mesh, and with this kind of a reconstruction, we are able to have relatively much better stability of the acetabulum cup into that situation. Our problem is instability at the transverse level. Now, this is kind of a standard pelvic discontinuity also, where in the classical situation, non-traumatic situation, we have various options over there. But in a trauma, what we have learned is out till you do not stabilize the column separately with the plate, you do not get inherent stability in that situation. So just like in this case, this was infected, debrided, totally discontinuity, we put up a plate. After the plate, we put up a cage and the cup over there to get this thing. Or this case, which was a simple acetabulum fracture, which was not fixed well, led to complication, replacement was done, which was not good, again that collapsed. So what we did was, we reconstructed the posterior column again, put up the graft, put up the cage and the cup over this area. Or this could be a bad comminution with the transverse discontinuity, where we needed a primary stability in this kind of a situation. And here we had to do a stability in the proximal of the ilium, then on the transverse level fixation, and then we could do this multi-hole cup into this area to give this patient the ability to stand and walk around. The last is the anterior column. These are the injuries where we have a reasonable stability between ilium and ischium, and we need to fill up anteriorly. And this anterior filling can be done by a simple bone graft supported by the mesh, or this case which was little neglected in this scenario, where we used a graft to put it over there, and then we put a cup over that, the cemented cup over there to give us a support. And this is the kind of the result we could get in this type 5 situations. Another case of a type 5 with the anterior column injury, again we have put a lot of graft into that area and put a cemented cup. We can always use uncemented cups if you have stable. Though various reconstruction we have done, number of disimpaction grafting, structural autograft, all these things we have used. And then the various procedures we have already named in these situations. Then in one of the analysis which we did about 2 years back was of the 209 cases, we could get back to 106 cases, and we used EQ5DL scoring system, and we found the outcome was not bad in most of these cases with the protocols which we are following up, the defining into a lateral type of a classification, and then making the reconstruction. And this is what we published last year in Journal of Orthopedics, and this year it is just published in the EORECON also as a surgical technique. So in this technique, so now we have defined this type 1 defect, a posterior wall, type 2 defect, a posterior wall, type 1 as intact rim, type 2 as a posterior wall defect, type 3 posterior column with posterior wall, type 4 which is a transverse kind of a discontinuity. It could be due to both column fracture, it could be due to transverse fractures, and type 5 which is an anterior column kind of a defect with their proposed mechanism of structural repair. Now we come to the another question over how often our reconstructions fail and end up in a THR, and the percentage is reasonably high. And now the understanding is why not to do a combined surgery of fixation and a replacement, and the literature is gradually building up. We have now the retrospective evidence also, the prospective evidence also, that in all patients who are more than 60 years, if there is a dome impaction, femur head fracture, posterior wall component is bad, it's better to do that combined surgery in one go. It could be definitely clear in the case which has got a fracture neck femur with the head dislocated, with the acetabulum gone, that you reconstruct the acetabulum and do a THR. Or it's a significant bone loss where in an elderly man you can't do the reconstruction. It's better to do a molars kind of a ring and a cup placement over this kind of area. The concern is these cases where the acetabulum fracture is very bad, the bone quality is very bad, and femur head is also very bad. These cases, there is no use of a pure reconstruction. So here we use a iliofemoral approach, fix that, and subsequently went with the posterior approach for the replacement as such. Now, this situation, and this was the kind of the result we obtained in this area. There is another case with the anterior column with an impaction over there in elderly. In this situation, we use the same iliofemoral approach and extend it down there as a direct entry, or Smith-Peterson approach, now so-called the Levin approach, and the fixation at the THR in one go. And this was the kind of the reconstruction we could get in this case. As for the midterm outcomes, they are not bad with this combined kind of a procedure, and these can definitely be adopted as an evidence. So when we sum up the issue of acetabulum fractures going for arthroplasty, we understand that in these cases, we need to plan the positioning very well. We need to take care of the defects caused due to the trauma, which might need a graft or a metal augment, depending upon the positioning and size of the defect. It's better to use a cup which have got a higher porosity, preferably multi-hole cup, or a dual mobility can be advantage to prevent the complication of a dislocations. And outcome definitely can be much better after that surgery, though it may not be equal to a non-traumatic kind of AVN. And we have always to look for that if they are operated upon, infection remains an issue in these cases. Thank you.
So that was a wonderful talk by Professor Dr. Ramesh Sen. all those who have joined late for this webinar. I take this opportunity to welcome you all on the behalf of Bombay Orthopedic Society. This is a webinar being planned prior to WIROC 2024. WIROC 2024 is due in next month in December at Mumbai. Our next talk today evening is by Dr. Neil Shade from the University of Pennsylvania. And Dr. Neil will be speaking on recent advances in the management of pelvic discontinuity in THR. Over to you, Dr. Neil.
Thank you, Dr. Kale. Thank you so much for the opportunity to speak here. I just want to make sure you guys can see my screen. You guys can see it okay?
Yeah, we can see it very well.
Great. Excellent. It's great to be with you guys this evening. It's 9:30 in the morning here, or 10:15 in the morning here in Philadelphia. And I love these conferences because I always learn something from some of the experience you guys have in India, which is tremendous pathology, tremendous complex patients that need to be taken care of, and there's always so much to learn. So these are my disclosures, which are not pertinent to this talk, but I've been asked to speak about what are the new and sort of update on techniques to treat pelvic discontinuity. And when I think about this over the last decade and a half, there's a lot of things that have changed with regards to what we're seeing and what we're doing for the treatment of these problems. Now, I had the opportunity, and probably the best sort of professional experience I've had in my career was to sit down with Wayne Poprosky and to download his brain over 40 years of what he has seen in the treatment of acetabular bone loss. And then as they started to see the concept and the nature of discontinuities that they were experiencing, and how do they define them. And so as a result, after this experience a couple of years ago, I put this talk together, which I've been able to put parts of this talk together for concepts of what we want to actually bring forth. And so if we think back in the 1980s in the United States, typically they were doing cemented total hip arthroplasty. But in the early 1980s, mid-1980s, they started seeing patients have early acetabular loosening. And they thought it was because of the cement, and then they started doing cemented acetabular revisions. And it wasn't until the late 1980s that they started doing cementless acetabular revisions. As they moved forward, it wasn't until 1990 that Wayne Poprosky and his team started recognizing that there were specific bone loss patterns. And it wasn't until sometime early 1990s, 1992, that they thought this was cement disease. This was what was causing all the bone loss. And Poprosky came up with his classification in 1993, but then published the original paper in 1994, 30 years ago. And what they started looking at was 4 specific components of looking at the hip center, whether it's migrated superiorly, what is the degree of osteolysis in the teardrop and in the ischium, and then Kohler's line has the hip center migrated medial to the line, which is Kohler's line, which is line number 4 on that X-ray. And in general, they saw type 1 defects where the acetabulum was undistorted, type 2 defects, the acetabulum was distorted. However, the columns were intact, and then type 3, distorted acetabulum, columns are no longer supportive. And these are the ones that we really worry about. But the up and out defects are 3A defects, up and in defects are 3B. And we really started worrying about type 2C, 3A, and 3B defects because these are the ones that were associated with a chronic pelvic discontinuity. So disruptive technology, this is an image from Krishna Kiran in Hyderabad. They started using cages and started using autograft. And this worked great. However, they saw that cages originally, just in the setting of discontinuity, did not do well. High failure rate, cages alone for discontinuity. In 1994, they started seeing ballooning osteolysis, and then they started seeing the same bone loss patterns with cementless revisions, and they realized in the mid-90s that osteolysis was due to polyethylene and not by cement. So again, structural allografts and impaction grafting came in the late 90s in order to solve this problem. So again, another case by Krishna Kiran, right, in Hyderabad, like the big allograft, and they had screws, K-wires to help guide your screw placement, and you're putting in a cementless device. If you look at this from Dr. Manktalau in Nottingham in the UK, again, now we're using some bone graft using allograft chips in order to do impaction bone grafting. It's a great case from Professor Schoors in Nijmegen, Netherlands. Bad discontinuities, bad defects, and these are 15-year results with mesh and impaction grafting. So done properly, these can work well. However, the allograft over time can fail, right? And these started to fail. So fast forward to 1998, there's a company called Implex that came up with an implant or a surface called tantalum. And it wasn't until 2004 that Zimmer Biomet actually purchased Implex and then introduced tantalum or trabecular metal as the trademark name for Zimmer Biomet in 2004. And what did they figure out? They had these augments. These were porous metal augments, and you figured out how to use these augments. Augments were not there just for bone void fillers. They were there for a specific purpose. If the augment was placed first, it was there for primary stability. They reconstructed a column or intracavitary reduction, like this series of images where you can see the reamers of 74. If I put that augment in first, secure it with 2 screws, now the real cup is 64 millimeters. It's 10 millimeters smaller. If you place an augment second, after you place the cup, this was used for supplemental fixation and typically placed posterior superiorly to, again, enhance the fixation of your cup. Augments were not to be used for just volumetric bone loss. 2004 until late 2000s, 2010, right? Now you have enhanced imaging. Custom triflanges started coming about in the early 2000s. And now you can see this defect, terrible on the left. You look at the 3D picture right here on the right, and now you're able to come up with a 3-dimensional acetabulum pelvis, and you can actually plan this case before you get into the operating room. And this is what the triflange looked like. Plenty of data out there showing pretty good results with the triflange, somewhere mid-80s to almost 100% in some cases. But there's an issue with the triflange. High cost, lag time for implant manufacturing, somewhere around 6 weeks. Planning preoperatively was complex. Bone loss patterns differed after your implant removal. So you thought the implant was going to come out easily. You thought that the defect would look a certain way. And then when you put in your triflange, it doesn't fit properly. There's also a tendency to lateralize the hip center. Complication rate's pretty high. And then dislocation rate was pretty high. And I think mostly because there's potential inadvertent injury to the superior gluteal neurovascular bundle. Let's look at the next decade, right? 2010, we get the cup cage technique, and then Wayne Poprosky starts to introduce acetabular distraction technique in around 2012, which we'll talk about. Cup cage construct, you've heard a little bit about this. And the cup cage construct has great results, right? Again, midterm to longer term data, pretty good. These are the last 4 years, 5 years, again, pretty good results. As you get further out, 10 to 15 years now, it starts to drop off at somewhere between 65, 75% with the triflange. However, the cup is typically placed too vertical and too retroverted because in order to accommodate the cage, that's how it has to be placed. And there's flange fixation in the ischium. When you have someone who has a lot of ischial osteolysis, it's hard to create a slot for that flange. And over time, that flange can fracture, which we've heard about already this evening. Inferior screw fixation, regardless of the technique that you use, we figured this out, right? Cups can fail in abduction. This is a patient that was sent to me 4 days after a revision total hip replacement. We had to re-revise them. A lot of augments and screws inferiorly in order to prevent that abduction failure. And this patient is now several years out. We learned this, actually, Krishna Kiran and I learned this together a decade ago, looking at the cup, and this looks pretty good. However, I was worried about the inframedial part of this cup, and over 6 months, this thing has pulled away and started to fail. So inferior screw fixation, really critical. We've come up with a technique that we wrote about 2 years ago on how to put that screw inframedially into the pubic ramus. How do you do this safely and reproducibly? And again, using these inlet and obturator outlet views in the OR to help you with this. We've started doing some screw orientation research and looking at biomechanics. You can see the bending stiffness is much higher when you have screws in all three quadrants. And then looking at this, some of the work that we're doing with the group in Adelaide, Australia, looking at interfragmentary motion and looking at motion in different axes. Again, when you have multiple screws, you can see how low the deformity is and the motion is. Same thing here. So options for discontinuity, I think right now, you can use a jumbo cup plus or minus modular augments. You can use a cup cage or a half cage, but there's some data out there. Custom triflange or 3D acetabulum component. I know that Harish Bende is going to talk about this in a short bit. And I think if we look at 2018 onwards until today, 3D printed technology has definitely taken a big enthusiastic push forward. And we're seeing these nice defects that have nice pre-op plans. This is courtesy of Peter Skulko at HSS, has shown me a very nice plan preoperatively, right? And you can look at the plan, you can come up with a model of the pelvis, you can put in the defect, the implant into the defect and figure out what you want to do. And early data was pretty good. And if I look at the last few years, a lot more data coming out. However, the mean follow-up is still pretty early. Okay, 75 to 100%, great. And these are really, really nice preoperative plans. However, you have to be careful. Look at this, right, from my friend out in England. You can see that bottom screw in the ischium is not in the ischium. It's out of the bone, and it's because the defect did not match your preoperative plan. My technique and my preferred technique is acetabulum distraction technique. And again, the reason that this came about, and Wayne Poprosky thought about this a decade ago, this allows for cementless biologic fixation. You have the ability to intraoperatively customize your construct, compression across the discontinuity, which hopefully will lead to healing of the discontinuity. This is what the distractor looks like. It looks like a lamina spreader. Okay, and this allows you to get lateral or peripheral distraction and central or medial compression across the discontinuity. These are some images that were created by one of our former medical students. You can see where the discontinuity is. You put the distractor in place. That causes compression across that discontinuity, but distracts laterally. You can ream in that position, put the cup, put augments if you need it. Take the distractor off. You're using the elastic recoil of the pelvis to hold your implants in place. And if you don't love your fixation, put another augment posterior superiorly. But at the end of the day, you're still going to cement unitize your augments to your cup. Couple of cases in the last couple of slides. 67-year-old patient, status post left total hip 16 years ago. You can see there's a discontinuity. There's some independent rotation of that inferior segment of the acetabulum. This is her 6-month follow-up x-ray. She's walking pain-free. And I can tell you that on some of the x-rays that we can get in the office, we're starting to see some bone fill in to that defect centrally. Another defect, 23 years ago, big discontinuity. This patient actually had an obturator artery pseudoaneurysm that needed to be coiled preoperatively. This is the x-ray in the PACU. This is the 4-year x-ray, again with inferior fixation, the dome technique, and again using distraction technique as the modality. If you look at the distraction technique data, again, 70 to 90% healing. This past year, we've written a couple of papers that were submitted to, and published in Journal of Arthroplasty, multi-center trial, mean 5-year follow-up. And if you look, cup survivorship was 89%, and radiographic bridging callus formation on the x-ray was 95% of these cases. Longest data series out there, this is between Wayne Poprosky and myself. Unfortunately, we had a number of patients that passed away unrelated to their surgery, a couple of patients that were lost to follow-up. So only a small cohort of 15 patients, but with mean 9-year follow-up, range 5 to 13 and a half years. And again, survivorship was very similar with 87% and 93% of these patients showing radiographic bridging callus formation on their x-ray. What's next? The last slide, or a couple slides. I had the opportunity to go to Adelaide, University of Adelaide last year with Bogdan Solomon, who is here in our image there. And he demonstrated some things that actually changed my practice completely. This is a patient that he put a spacer in, bad pelvic discontinuity with a lot of bone loss and infection. This is the reconstruction that we did with no x-ray, no C-arm, nothing. And during that entire case, he was able to identify the superior gluteal nerve and isolate it and protect it. And I had this case, thankfully, 4 days after I returned. big 3A defect, big acetabular bone loss. A lot of the bone was gone once you take the cup out. Cup fell out, but I was able to find the superior gluteal nerve, which is now here protected with this small vessel loop. I'm putting in cement and I'm putting in, and you can see how big that nerve is. It's way bigger than I've ever appreciated in my entire career. But this is the construct post-op. And the nice thing is that the Bogdan Solomon now at the end of the case will actually innervate intraoperatively the abductor to make sure that that superior gluteal nerve is intact. So I think this is the next level for what I need to do. We're starting to work on some things, Dr. Solomon and I, looking at the supragluteal nerve anatomic variations and what we need to change. Regardless, all of these patients for me with these big defects, I see them at 2 weeks, 6 weeks, and 12 weeks. If there is no interval change in their X-ray in the first 2 to 6 weeks, I will make them touchdown weight bearing for the first 6 weeks, advance them to 50% weight bearing over the next 4 to 6 weeks. It takes about 3 months before they can be weight bearing as tolerated. And I usually have them use a walker and use one of these braces for their hip, which helps the helps the physical therapist to understand that they should treat these patients differently than a primary total hip. Thank you for your attention.
Thank you, Dr. Neil, for that lucid yet a very descriptive talk. Indeed, that method of distraction in chronic pelvic discontinuity that has been kind of like patented by Wayne Paprowski, Dr. Neil Shett and his group, and that has been a landmark, or it has set a new benchmark in managing this complex case of pelvic discontinuity. We'll take questions on your talk in the later part of this webinar. We move over to the next talk, which is by Professor Dr. Harish Phinde, a senior arthroplasty surgeon from Mumbai. And Dr. Harish Phinde will be speaking on the role of 3D printing and the custom-made implants in acetabulum reconstruction. This is a newer technology which has come in this field of acetabulum reconstruction. Over to you, Dr. Phinde, sir. So you are muted. Can you unmute you?
Yeah, I unmuted it.
Yeah,
I hope you can hear me now. I'll try to share my screen.
Yeah.
Can you see it?
No, sir, we can't see your screen. You haven't shared your PPT yet.
Oh.
So you may double click your desktop screen.
Yeah. Now
Yes.
can you see it?
Yes.
Yes.
This is rather than giving a lecture, I would like to just show a small film exactly how we planned a difficult case. The patient had an infected hip, which was removed by some surgeon. They did couple of debridements, and the patient was left as an excision hip, as you can see on the screen. And he has a significant defect, and we were supposed to reconstruct that as a hip replacement surgery. So this is how the X-ray looked. You can see there is a significant posterior defect, there is significant anterior defect, and the whole hip is more of like a flat surface anteroposterior. You can see the CT scan immediately. We took a CT scan to assess exactly how much is the bone structure which is there. And you can see that on the affected side, the bone is technically flat. There is no posterior wall at all. In the horizontal section, you can see that some amount of anterior column and anterior wall is there. So we had to reconstruct that. This is a vertical section of a CT scan. You can see that thus again it is entirely flat. You can see there is hardly any dome which is there, as you can see on the opposite side to compare. So we had to reconstruct because had we used a standard one, we could have used a big amount of insert or augments. So this was a 3D printed thing which the company gave it to us. We have to take a 3D CT scan, gave it to them. They got a 3D model. And this is the initial one, the 3D printed implant which they gave it to us. Technically, once they give you the implant, we have to decide which implant is good. So we had to reduce the size of their footprint of the posterior part because it was coming too close to the sciatic notch. So we told them to remove that portion, and they removed and remade another model, and they put the screws in a direction using the 3D data so that the screws, if you go in that same direction, they can tell you the size of a screw and depth of a screw, so you don't perforate the bone and go beyond it. So this is what was the footprint we accepted on a bone model. And once that is done, and once we approve the actual design and a size, etc., then they actually manufacture the implant with titanium with 3D printing thing. So this was the final model which we accepted, and this is how it was sitting on a bone model. This was the actual implant they sent to us, again sitting on the same bone model. And this implant is then cleaned, autoclaved, and used during the surgery. And the bone model also can be autoclaved, also can be ETO'd, and we can keep the bone model during the operation, and so that the uh, so basically this lateral incision was taken, and you can see that you have to go through the posterior approach. The same approach was used by the previous surgery. Now this patient has almost no abductor attachment. The previous surgeon, while removing the implant, has technically removed the entire abductor attachment. What you can see there is the top of the trochanter, and you can see that the top of the trochanter technically has almost no soft tissue attachment over there. We had to dissect the gluteus medius, gluteus minimus and maximus, and you can see those muscles which has been separate from the trochanteric tip. We had to identify them, make sure that they are reattached to the trochanter tip at the end of the surgery. Now, we went by the posterior approach. We exposed, because the trochanter was detached and the abductors were detached, we had to separate them. You can see that the posterior part is gluteus maximus, anterior is a gluteus medius. We approach the same thing as we do in a posterior approach. You can see the amount of fibrous tissue which is there. Deeper to that, you have to dissect it up to the point where you reach the bone, and you have to then identify. This is the posterior distal part of a flap which is done by releasing the gluteus maximus tendon insertion. This helps you to actually take the trochanter anteriorly and expose the acetabular bone completely from front to back. So you develop the posterior flap from the back of the trochanter as you do normally, and then shift the trochanter anteriorly. So this is a posterior flap being developed. You use all the soft tissue from the back of the trochanter, which include, at this level, quadratus femoris muscle and some portion of a posterior capsule which is attached to the base of the neck. You can see that below, inferiorly, you can see the dissection going on along the inferior part of a neck and going down almost as much to the level of the lesser trochanter. You can see the lesser trochanter being exposed there. And once that is done, once you identify the capsule below the neck, then you use the hook and push the femur in the front. Now here we have exposed the acetabulum, and what is very important in this situation is, once you expose the acetabulum, you have to go directly on the bone and remove entire soft tissue from the bone surface. So you use a sharp dissection either with a knife or with an electrocautery to remove all the osteophyte. Now, while doing this, when you see the bone during the surgery, you have to feel the bony fragment and the bony contour. And what helps you is you can use the bone model which has been given by the company, which is ETO'd by you, and which can be used during the surgery, kept next to you, so that you exactly know where exactly you are dissecting, and a particular bone elevation or a particular bone depression is exactly where with respect to the rest of the acetabulum. So you can see that we are now removing the soft tissue all along the bone. It is important to clear the bone completely, because unless you have got a raw bone exposed and remove all the soft tissues, your implant will not fit very well into the exposed area of the bone. So this is the exposed acetabulum, and you can see, comparing that with the 3D model. If you can take this 3D model on the side of it, you can see very soon. You can see exactly which parts of the acetabulum is exposed. Now, this is a inferior wall that is somewhere near a transverse acetabulum ligament, and you can see towards you is the posterior wall of the acetabulum, which is very damaged and defunct. Anterior, you can see some portion of a bone. So we are identifying various landmarks, and here you can see, let me go a little ahead. And that's the bony model which is there, which we have kept next to the surgery. And you can see that the bony defect extra can be seen, and the bony contours should be identified. Now, this is where we have done the reaming on the bony model. And when you start reaming, you have to identify the area in which to start the reaming. You know the size of a reamer, because the implant company actually gives you what size of reaming you need to do. This was size 52. And so we start reaming from the base of the acetabulum. And as you start reaming slowly, you look at the picture of the reamed bone and compare that with your acetabular bone model. And when you do that sequentially, you can get the more or less similar picture on the acetabulum. There is a 3D guide which is also prepared by the company, which we can use to guide the direction of your reaming, because the commonest error is you may not ream in a proper direction and proper angulation during the surgery. So there is a guide which can go on a 2 guide wires, and that can also be used if you have any difficulty in doing the reaming. So that's the primary reaming which you have done, and compare that with the bone model kept on the side of the surgery. You can get rough idea about the amount of reaming which you have done. So this is the actual intra picture of the rimmed bone, and you can see the bone model being kept next to it, and that bone model would look somewhat similar to whatever is there in the rimmed area, and that's the ETO'd plastic model of the actual implant. And you can see that this implant would sit into the rimmed area of a bone like this. So this is the actual implant which is being used, and it has a handle on which it is mounted. The outside is made rough so that it allows the bone in growth, and all the screws are specifically marked to go into specific direction so that they don't exit the bone, they don't injure any neurovascular structures. So you can go according to the direction given by the company, and they give you a chart. In the chart, it is given which is a screw which has to be go in which direction, and what is the depth at which you have to put the screw. So it is all pre-decided during the pre-surgery planning by the surgeon with the help of 3D CT printing and 3D scanning. So we put this implant inside. If the reaming is reasonably adequate, I had under ream by about 1 millimeter. So as to get a little bit of a good press fit, and then we implant and hammer the gently tap the custom-made implant into the rimmed area of a bone. And you can see that because it is sitting on a 3-dimensional area of a bone with different contours, even before putting the screw, this implant is reasonably stable. It is fitting very well inside the contour and rimmed area of a bone. So primary stability is very good. Now I put the screws into the various screw holes, and you can have multiple screw going from the outside of the implant into the acetabulum bone, as well as implant screws going within the implant, going vertically up. So it's very important to put the screw in all the direction, and you can put screw also in the ischial tuberosity to get a better 2 or 3 plane fixation. That's a trial cup which we wanted to see exactly which one is going to fit well. We knew it exactly that we had to use 47 side cemented cup into this. So this is how the cup would look after cementing. We can adjust the alignment, orientation, etc. depending on whatever we want during the cementing process. So we exactly decide exactly how do you want it. And then we put the cement inside the cup. We pressurize the cement to go into the various crevices into the rough area of the inside of the 3D printed cup. And then you put the actual cemented cup implant by putting extra cement around it. So once we do that, we pressurize that cup implant with the help of a cup holder. We have to dry up the cement before putting the implant. We have to, with hand pressure only, we can use some kind of a ball to push the cement inside the crevices of the cup, dry up the cement, and then we can put the actual implant cemented cup inside this. So this is a cemented implant. We have smeared that with the cement on the surface, and this is then pushed inside with the help of cup holder and then a single ball. So once you start pushing it in, it goes adequately in you give the actual direction of version and inclination which you want, and that can be changed during the surgery by a few degree plus or minus. We wait for the cement to settle down and harden. And once the cement is hardened, then we remove everything, and then we go for the reconstruction of the femoral side. Now, this particular patient has an extend hip with significant shortening, so we had to actually use the subtrochanteric shortening to reduce the risk of sciatic nerve pressure and sciatic palsy. So we used SROM implant for this, and after preparing the primary SROM implant in the proximal part, then we went down, did the subtrochanteric shortening so as to reduce the length and reduce the pressure on the sciatic nerve. So that's a trial SROM implant being put into the proximal part of the femur. Once that is done, we go down, do a shortening of implant just about a centimeter below when your sleeve is going to be there. You can see those things are marked. And then you take a horizontal osteotomy and remove the segment of a bone which is required based on your initial planning. So once you remove this, you can put a trial cup, reduce the trial implant, and see how much overlapping happens between your distal part of your stem and a proximal part. And then you put the final implant. You can see that that part of the surgery is eliminated from the actual the screen. You can see that this is the final cup and the stem which is put. We have put a ceramic head inside, and you can see that osteotomy is closed very well because we can impact that osteotomy with the help of SROM implant very well. And that's the final stability of the patient. This is a post-op X-ray of a patient, and you can see that when you analyze this X-ray, because we have planned the position of acetabulum very well, we tried to see how much restoration of anatomical landmark has been achieved. So we did the center of rotation of the cup. That's how my initial implant was planned, and that's how my one sec, it has gone back. So that's how my initial implant was planned, and that's how my initial post-surgery X-ray which looked like. And when we actually took an X-ray of pelvis with both tips AP and compare that with the opposite side to see exactly have we restored the center of rotation of the acetabulum and the height, you can see that the center of rotation of acetabulum is restored within 79.1 millimeter distance from the normal, and the height of the acetabulum, that is the vertical length, is restored within again 0.5 millimeter. So you can actually get a very good accuracy of placement of your implant and restoration of the biomechanics. So basically, this is just a way to show exactly how the things are done.
Right, sir. We are hearing, sir.
This is one of the best probably way and relatively easier way to restore the difficult cases to as normal biomechanics as you can, because you have restored everything based on your 3D printed implant. I think that's
Right,
about
sir.
it.
Wonderful presentation. And it's virtually the only option left in such cases when
Can
we cannot
you?
construct.
I'll stop sharing my
Stop
screen
sharing.
now. Okay. Any questions? Anything you want?
Yeah, I think we'll take all the questions after the talks are over. Wonderful.
I'm not able to hear you.
Can you hear me now, sir?
Can you hear me?
Yeah, we can hear you. We are hearing you. We are hearing you.
Bidde, sir, can you hear me?
Yeah, now I can hear you. Sorry.
Yeah, sir. So sorry,
Yeah.
we'll be taking the questions at the end.
Okay, good.
Dr. Anup, please continue.
Yeah. So after that wonderful talk of custom tri-flange cup or 3D printed, we now invite Dr. Vijay Kumar on a very interesting talk of a revision of an intrapelvic cup and what precautions do we need to take? How do we extract that cup? It's all over to you, sir.
Yeah, hi everybody. We are friends here. Good evening and good morning to Dr. Seth. So can you see my screen? Is it
Yes,
it
it's visible.
okay?
Go
Fine.
ahead.
So I'm going to talk about intrapelvic cups and how do you stay safe in it. Well, what's a intrapelvic cup? Basically, an intrapelvic cup is something when the acetabulum is right there inside the pelvis. So, it is said that when the material has passed inside the passes the pelvic inlet, and normally it is mostly infection, or it can be a mechanical loosening, malposition of the cup leading to chronic instability, or it might sometimes be a traumatic injury also, though that is rare. The challenges in this are you have a lot of noble structures inside which are at risk. Uh, it is usually associated with infection. Deciding the approach, whether to do it in a single approach, two approach, that's always a dilemma. And finally, the reconstruction also. So I'm going to present a series of cases. Before that, what are the structures at risk? This was an article by Christian Back, and he found out that there are lots and lots of structure inside, and he also did a literature review, and he found that the most commonly injured structure are the vessels, of course, but in addition to the vessels, you have the bladder, the sigmoid colon, the sciatic nerve, the iliopsoas. So these all structures are also at a risk when you are planning for a revision of a intrapelvic cup. And a clinical examination is utmost important in these cases. You need to assess whether there is any signs of neurological deficit or irritations, specifically of the lumbosacral plexus, which would give an idea what is the involvement like, in addition to any signs of any urinary problem, digestive problem, or in a females any gynecological issues also. As far as the anatomy is concerned, so the vessels are more close on the left side as compared to the right side. And you need to know, so there are three variation of vessels. One is the straight one. So if it's a straight artery, so it is less risk of damage as compared to the curved type or a double curved type, or the tortuous type vessels. So these are anatomical variations which are seen in in human beings, and it is seen the vessels on the left side are more closer to the acetabulum, and this is because the left side is the less dominant part. And it is also seen that in patients, elderly patient females also, the vessels are closer, because here the volume of the iliacus muscle and the psoas muscle is smaller and is lesser. And the other thing to remember is the obturator vessels are also very close by. They are where you put on your inferior humen, so they are just located behind the acetabulum there near the obturator foramen. So these are the vessels that you need to be knowing as far as the anatomy is concerned. Preoperative CT angiography is must in all these patients, in all patients where there is an intrapelvic cup, or you are going for a revision and you have screws going inside the pelvis. Here you always do a CT angio and see what is the distance of these vessels with respect to the cup, or the or the screws, whether it is a safe distance or not. If it's a safe distance, you can easily go ahead and do it. If it is not a safe distance, then you need to do some sort of intervention. In addition to CT angiography, you need to do a urological workup also. So you can do a opacification of the urinary tract, or normally what you do is in the late phase of the angio CT, when the dye is being excreted through the bladder, you can have the shadow of the bladder there, and you can come to know whether how close is the bladder like. There can be fistulas, uteroacetabular, uterovaginal fistulas, as well as fistulas between the GI tract and the hip. So you need to be careful in these patients. The most important part is most of these patients are they have infection, and it has been seen that as high as 50 to 60% of these patients who have got a intrapelvic prostatic migration, they are infected. And this is because of the secondary communication between the subperitoneal space and the hip joint. So a threshold of a single stage revision should be low, preferably in a two-stage revision if they are not overly infected. So how do you approach? So one can be a conventional approach, but you need to be careful there. And even in a conventional approach, sometimes you require a ETO to take out the stem, because it's not so mobile. But in addition to that, you need to know one of these subperitoneal approaches or transperitoneal approaches, or retroperitoneal approaches to take out the cup. And you should have a pelvic surgeon with you, or a general surgeon with you, when you are taking up these cases. So it can be a two approach, where intrapelvic cup is removed by by an abdominal approach, and then you go ahead and remove the stem from a posterolateral or the anterolateral approach. In addition, you can even try a single approach. This has been, some authors have tried to do it and have prescribed this to be done, because they found that the conventional hip approach is more common, more familiar, and further, if you go transperitoneally, the risk of infection, ileus, and bleeding is greater. However, one needs to know that, if the vessels are close by, then you need to be very, very careful if you are trying to do it purely by a conventional approach. So, we have a series of patients where we use the conventional approach, but our dictum was that we always get a preoperative CT angiogram. If there is any vessels nearby, it is embolized either temporarily or a permanent coil embolization is done. In some patients, in fact, we also use we have a vascular access immediately before the surgery, and we insert a vascular balloon catheter which is left in position to be inflated in case there is an intraoperative vascular injury, which fortunately we did not have as yet. So we have had around 15 cases in which, we had 4 were embolized temporarily, 5 patients permanent coil embolization was done. Balloon catheter was in 6 cases. 9 of these cases have had first stage revision and still waiting, were infected. Revision total hip second stage was done in 6 cases. So just showing you some cases. So this is one of the cases which came to us with the cup which was right inside, and you see the artery is very close by. Here, coil embolization was done. This is a coil embolization which has been done, and thereafter, the reconstruction was done using a cage along with a lot of bone graft, which is now around 3 or 4 years now. And this cage that we use is a cage by the Link companies, comes by the name of CombiR, and they say that it integrates. Our results still around 5. We have been using it for now 6 to 7 years. They have been pretty good. So another case in which another intrapelvic cup, in which you see the cup has totally gone inside here. There was a mesh also along with this. So here again, so these are the subsequent x-rays. So here the vessels were closed. Here we used the catheter inside and we removed the cup, and this only the first stage has been done. So it's still waiting the second stage. Other patients similarly here, if you see the coil, there's a coil embolization was done and is again waiting the second stage. Other patient in which the catheter is put from the other side, so you need to be careful. You need to have a good intervention radiologist with you who does the catheterization just before the surgery starts, and you have to be careful by positioning the patient that the catheter is not dislodged in any way. And then you go ahead and do the surgery. So it is basically a prophylactic measure in order to, if there is some bleeding inside, so you can have control by inflating the balloon here. So this is how it is. So this is the post-op X-ray. Another one patient in which, this was the obturator artery, which was very close by, coil embolization was done and revision was done in a similar patient. So another case. This is another one case in which, a temporary embolization was done, and then first stage was done, waiting for second stage. This is another interesting case in which there was a periprosthetic fracture with the cup totally gone inside. Here again we used the vessels were close by, so we went ahead and used the balloon catheter from the other side and did the first stage. Another of these patients, and this is another patient in which this came for revision. The vessels were one of the superior gluteal artery was very close by to the K wire. So here embolization was done and then a revision was done. So to conclude, consent should be taken. Always rule out infection in these patients. A vascular workup is necessarily. Surgical approach needs to be decided, and always have a pelvic surgeon along with you, or a general surgeon or a vascular surgeon there. Maybe done in a single or 2 stage depending on the case. And the reconstruction, usually you require cages and plates along with allografts. I thank you for attention.
Thank you, Professor Dr. Vijay Kumar, for that wonderful talk. It's something, the frontiers of acetabulum reconstructions are expanding, and that's probably something new that we are coming across about how to prevent vascular catastrophe intraoperatively. Now we open the session for discussion. Any questions from any of the panelists? Anup, you are muted. Anup, you are muted.
Yeah, a question to the panelists. I would like to have a take of all the esteemed panelists. most of these revisions, they are fraught with a lot of exposures, and the patients run with a very tumultuous post-operative course. May it be blood loss, the wound healing is a problem in most medically challenged patients. Uh, what is your pre-op and post-op way to handle these extensive revisions? And Dr. Neil sir and Dr. Vijay sir and Dr. Harish sir.
Yeah, Anup, let me give my thoughts. So on some of these patients, I just had a patient on Wednesday, 87-year-old lady with a big cup that's intrapelvic, been there for years. I brought the patient in actually 2 days before surgery, got her seen, nutritionally optimized, right? We've done all these things to get her in the best shape possible prior to doing the surgery. I think the more pre-op planning that you do, then you can spend less time in the operating room trying to figure out what you want to do. You know ahead of time what it is, and we can do that case and we're done in 2 hours, right? The less time for that patient on the table is better for them. So I think it's a mix of preoperatively optimizing these patients as much as you can and doing as much pre-op planning as you can, so that there's not a lot of time spent in the OR trying to think. You're just executing a plan you've already thought about.
Do you generally keep drains? What is your protocol on
I do.
acid?
Tranexamic acid for everybody, whether if they have some contraindication, which really there is none, but our anesthesiologists still kind of block us, we will put tranexamic acid topically in the wound. I typically put drains superficially, so outside of the fascia. So as they're getting up and mobilizing, if there's fluid that collects there, I'd rather that fluid come out than to put pressure on the incision that's above it, right, superficially. So, but I don't put in drains deep.
Right, right.
Neil, Harish here, sorry.
Yes,
I'm sorry, my video is not working. So I think audio, can you hear me?
yeah.
I can hear you, Harish, and I know what you look like, so I don't need the video. It's fine.
Okay, great. Thank you. Do you do a lot of 3D printed implants, acetabulum implant basically? Because the femur side we don't need. Most of the thing available
Right.
is there. I never found necessarily do femoral side 3D printed implant. But
Yeah.
acetabulum, do you do, and what difficulties do you find using them?
So Harish, I've never done a 3D implanted. I've never actually used a cage in 15 years. My big concern with 3D implants is, even if I look at your post-op x-ray on the case that you've done, I'm not worried about you using that implant. I do worry about the surgeon that's is less experienced, because if you look at your pre-op plan, you had a nice big screw in the superior pubic ramus, and your post-op x-ray does not have one. That tells me that your implant did not fit exactly to your pre-op plan. And if you can't tell in the operating room whether that is the case or not, I think then you can be in trouble, because you're trying to put that 60-millimeter screw that you pre-op planned. So I don't have any experience of using it. For me, and again, this is a definite big bias because I trained with Wayne Poprosky, and for me, I look in the operating room. I could care less if you have a discontinuity. I don't care what your bone loss pattern is. I will use my augments for a specific purpose. If I have a discontinuity, I'll use a distractor. And then intraoperatively, I have the ability to customize my construct and create the construct that I need to fix this problem. Does that make sense?
Yes, sir. A lot of sense. Just taking.
Yeah, Harish, I'll just add to it.
Yeah,
You
Dr. Vijay.
This was, I think the second case in this series only. I had a 3D printed implant for that. This patient is now, 1 year post second stage. All markers of infection were negative. We did an aspiration negative. We did a 3D printed implant for it. It cost around 2 lakh rupees or something. We went inside and there was pus. So, I'm, and now that has been printed. So, I just washed it and, tried to do, as little as possible. Did not put in a, spacer also again, because if you put in a spacer in the acetabulum, it might eat away the bone. And I'm hoping for, another 2 months down the line, I'm going to go in again and try to put in that 3D printed implant, because it's already printed. So, the cost is already there. But that is, something, something when it can go haywire. Yeah.
And
There
Vijay,
are
you bring
two,
up
three
a very
things we
good point.
find.
Sorry, Harish, go ahead.
2-3 things we find difficult, because it looks very fabulous and very fancy when you use the 3D printed implant, and show to the patient that, look, this is what I'm going to use, and my screw will go there and my screw will do that. And then on table, number one is, unless you are actually able to expose the bone like a dry bone, the implant doesn't fit in very well.
Yeah.
Because even if you leave some amount of soft tissues there, that implant is going to change by maybe few degrees. And where the screw want to be in between a nice good iliac wing or XYZ place, it go 5 degree here and there, then you may not be where you want to be. Number two is, you have just one option which is pretty expensive. Either you use it, if you don't use it, in Indian scenario, throwing about 3 lakh rupee implant down the drain and saying, no, I will use now the standard one with augments, becomes more difficult, because you are adding to the cost. So that's the second thing which is very difficult to know. And third, obviously, we do not know the long-term outcome of what the strength of this implant when you are loading it, especially if you have got the defect which span your medial and lateral columns, and which is not very solidly, bony fused, and you are just spanning because of the implant which is going across. So it's like a cup and a cage blended into one single implant because of the 3D printing. But we don't know whether how strong they are, and do they withstand another 20 years of where some 2-3 million cycles of walking. So these are three things which you found. So it looks very fancy and nice, but I don't think that will go in a very big way. It's always better to get something which is customizable on table. So you've got more than maybe 5 or 6 augment. You have maybe more types of augment, maybe more options. You can fill up every nooks and cranny of the bone, and then select your standard implant, standard cup, whichever is available on the table. That may be the better option in the long run. Otherwise, I don't think a
Harish, I
big
think
future for this.
these are very, very good points, but I mean, it's the same thing. Again, I'm never concerned about people like you who have so much experience to recognize those small nuances in the operating room. I'm worried about the surgeons who are less experienced, who are still learning, who are going to see these problems, right? They're going to face them in the operating room. They're going to see them in the clinic to say, hey, I have to do something. And I agree. I think the customizable implant is very nice, right? You can fine tune what you think you're going to do, but it's so dependent upon what your bone defect looks like once you get the exposure and you've taken everything out. If you lose a little bit more bone in one spot than the other, and you're 2 degrees off, 2 degrees off at the end of your 60 millimeter screw is a huge variation. So no question. And then I think in India in general, the cost issue is a big difference, right? I mean, there's patients are paying for some implant that is 3 lakh rupees, and then you don't use it. That's a big problem.
So when have you found the need to explant an well-fixed metal augment? And what are the tips to prevent bone loss in those secondary revisions?
So Anup, I'm assuming you're asking me. So that is actually a problem that is very difficult, right? When you have augments that have incorporated, that have ingrown, in order to take those augments out, you're going to lose a lot of bone. So I have a handful of cases where that have gotten infected, where I've taken out the cup and explanted the cup, but I've left the augments. I've put in a spacer, I've put in a big ball of cement, I've put in a Prostalac cup with cement, with high-dose antibiotics. We've cleared the infection and left the augments there as almost their native bone, and then reconstructed around it when we come back for the reimplantation. So yeah, but I think on the augment side, I think on the customized implant side, taking out implants that are infected are very challenging because they don't fit your normal contours of what you can take out with a cup.
All right, so
Another question to Dr. Neil Shade. So last year you published a paper on the kickstand screw. Yes. So some practical tips and tricks, because at times it's very challenging. That's very important to pick it in most of the X-ray that is missing. But that's what will prevent the abduction failure of the cup.
Yeah. So Abhijit, again, Krishna Kiran and I learned this together, I think early on in our career, about 10, 12 years ago, where big case that he did, and he showed me the X-ray and I said, this looks great. I said, but I'm concerned. And then in 6 months, that case failed, right, in abduction. The problem you guys have, Abhijit, in India is that you have patients who are very small stature. That means their superior pubic ramus is tiny. You have a very narrow corridor. And then patients who have a lot of osteolysis in the ischium, you don't have a good fixation strategy for the ischium. So we wrote a paper 2 years ago, which has an associated video with it. It's JBJS Essential Surgical Techniques on what X-rays you need to get in the operating room. It's the inlet view and operator outlet view, and that can help you in two planes, orthogonal planes, to show you how you can thread the needle and be able to get that screw down the pubic ramus. And for me, I'm always looking to get a 35 to 50 millimeter screw down the pubic ramus in every one of these big cases, because I don't want that cup to fail in abduction, like you stated.
Thank you. Thank you for that technical tip. For the want of time, probably we will now move to the closing remark from Professor Dr. Mohan Desai, who has been chairing this meeting. Over to you, Dr. Desai, sir. So you are muted. We can't hear you. Dr. Desai, sir, you are muted.
Okay. So it has been a great webinar. Nice to listen to all these people, masters, Professor Neil Sheth, Harish Bhende as usual, and Dr. Vijay Kumar, Dr. Ramesh Sen, of course. And there was always some points here and there to learn and tips to take home. And it was really nice. I'm sure our audience there listening to this webinar must have learned a lot from this webinar. Thank you, doctors, for sharing your tips and tricks here and pearls of wisdom.
Thank you, sir. So before we close, Dr. Anup, can you highlight us what is new at the WIROC, which is scheduled from 20th to 22nd of December at Mumbai at JW Marriott Hotel? Yes, over to you, Dr. Anup.
Right. So what's new this time? So we
Yes.
have got an innovator summit where we are having surgeons presenting their record or path-breaking innovations. We have got video symposiums where people will be showing their technique of doing conventional surgeries. We have got legends presenting their surgical real-life videos. So we hope to soak in their knowledge and grow in the knowledge sharing as well. At the same time, we have got a lot of engaging debates that are going to go on. We are going to have a lot of workshops that are going to be engaging arthroplasty surgeons into robotics, partial knee replacements, new osteobiologics or orthobiologics, as they say. They are being displayed on WIROC 2024. So all these things are up there, and I think we can continue this discussion when all the faculty join us for WIROC 2024 in person. I hope to see you all.
As all good things have to come to an end, so will this good webinar is coming to an end. Let me thank on behalf of Bombay Orthopedic Society, Professor Dr. Neil Sheth from the University of Pennsylvania, USA for joining this. Professor Dr. Vijay Kumar, who joined from AIIMS, New Delhi. Professor Dr. Ramesh Sen from Chandigarh. Professor Dr. Harish Bhende from Mumbai. Our Honorable President and the organizing chairman of WIROC 2024, Dr. Mohan Desai, and my friend and colleague, Dr. Anup Dhamangaonkar, who is the organizing secretary for WIROC 2024. Let me bid adieu. Good night to fellow Indians and good day to Professor Dr. Neil Sheth.
Thank you, everyone. Thank you for
Thank
including
you,
me in
everybody.
this great
Thank
session.
you, everybody.
Thank you very much.
You.
Thank
Great.
you.
Thank you, everybody.
Thank you. Bye-bye. Bye-bye.
I'll shut down the live stream.